Okay, well let's get going. So my name is Khaled El Emam. I'll be presenting in this webinar today. I'm a professor at the University of Ottawa. I run a research lab at the Children's Hospital of Eastern Ontario Research Institute, and I'm a co-founder and CEO of a company called Replica Analytics, which develops methodologies and technology for synthetic data generation. I will start off with just a little bit of logistics to help us understand what the plan for the next hour will be. So the webinar will be 1 hour. I'll make sure to stop on time. All the recordings and materials will be made available afterwards. So within the next 2 or 3 days, you'll receive an email from me with a link to the recording of this webinar as well as the presentation materials. Plus any other reference material that you may ask about during the Q&A. I can send you copies of that as well. At the end, there'll be a chance to ask questions. There'll be a chat box on your Zoom screen. Oftentimes there are more questions than time, so I've planned to leave a little bit more time for this webinar at the end for Q&A. So please think of your questions if you have any. Type them in early if you want, and then we'll look at the questions at the end of the presentation. And of course, you can always send me questions afterwards as well. I'll give you my email address. You can send me questions by email. I'm happy to answer them or provide you more information after the webinar. I'll also keep you updated with future events and publications that may, from my lab, my research lab, and from the company on this whole area of data sharing, secondary uses of data, and the privacy of health data. So let's get started with the main presentation. So I have been involved in the health data ecosystem for over 15 years. My role has been to enable organizations to share their data by providing governance, support, analytics capabilities, change management advisory services for how to share and consume data, as well as data protection methodologies and technology. These types of roles mean that I've been right at the center of many data exchanges that have been occurring over the last decade and a half. So my objective today really is to share some of these experiences with you with a particular focus on data monetization. The perspective I'm going to take is that of the secondary uses or disclosures of the data. This means that the data was originally collected for some other primary purpose, such as providing care to patients, and then the monetization is to drive some secondary purpose different from that primary purpose for which the data was collected. My starting assumption here is that secondary uses and analysis of data are a good thing. They are a key part of health research, whether it's commercial or academic, and it results in improved treatments, drugs, and devices that are beneficial to patients. Secondary analysis can drive improvements to health systems as well. Health data can also be used to market goods to patients, and if done responsibly, this is a legitimate use of data and a legitimate practice. I'll come back to this issue again during the presentation when we talk about social license and legitimacy of data monetization. So there will be uses of data that are going to be controversial, and this is why I emphasize the terms responsible uses and disclosures of data. Later on in this session, I will also discuss social license and governance. At this point, I'll just say that there are beneficial and legitimate secondary uses of health data that provide a lot of societal and economic value to society, and that is the starting assumption that I'm going to make. Okay, so let's get started with the 10 things. The first one I will talk about is the supply of data. So over the years, I've spoken to many organizations who are interested in monetizing their health data. These are different types of organizations. varying from health IT vendors, such as those building electronic medical record systems for hospitals and clinics, to medical device companies, hospitals, insurance companies, pharmacies, laboratory services companies, pharmaceutical companies, and research registries. Therefore, these conversations and inputs cover the full spectrum of private sector, commercial, to academic users of data. There are also public sector and government departments that have been trying to generate revenue from monetizing their data, sometimes just for cost recovery, sometimes to reduce rates. They charge the public for specific services, and sometimes to subsidize other activities at the organization. All that to say that there is a large supply of health data. In general, it's not that hard to find multiple sources of different types of data. And there are some exceptions, and I will cover those as well. But the obvious exception worth mentioning now is the government data, where there may be only one supplier because they're the only entity collecting certain kinds of data. But in general, there are lots of data available, and a lot of organizations are trying to monetize their data. So there's a good chance, if you are trying to monetize your data, that you have competition on the supply side. And in some cases, I would even argue that data has become a commodity. It's also becoming easier to find data. A good example of that is the new Google dataset search. I'm not sure if you have seen that, but it helps users find data that have been described using the schema.org vocabulary. So you can search for data sets that are available online. They may not be public data sets, but they're described online, and you're able to find them and then contact the data suppliers. This has made it much easier to find data as well. There are also a number of commercial data brokers with significant data holdings. And as the role of real-world evidence increases, data collected through routine care will be more important. Regulators are increasingly accepting real-world evidence and real-world data in their submissions. For example, analyzing existing data is much cheaper than running a clinical trial, and therefore, if real-world data is acceptable or real-world evidence is acceptable as part of submission, it's a much more cost-effective way of providing that evidence. Therefore, the demand for this kind of data is also going to increase quite a bit. If you have data, then this is potentially good news in that there are definitely interested consumers in that data. And the number of consumers is very likely to increase over time. These consumers can be internal or external to the organization. A major theme of my presentation will be that there's significant value to be gained from internal analytics of already existing data. I'm seeing a very rapid increase in internal demands for data within organizations. So in that case, the organization has had data or are collecting data, and they've had data for some time, but they have been unable to utilize that data internally for analytics for various reasons, data protection and privacy being one of them. And we're seeing now that there is a rapid increase in demand for access to that internal data. So it's not just monetizing data by making it available externally, we're also seeing demand for data internally. Also, to avoid mentioning any companies or businesses, I'm going to be general, and will describe overall trends and directions in the market, at least from my perspective. The trends that I have seen are global, although some regions are moving faster than others, but I think the overall message is things are happening around the world, or directionally anyway, things are moving in the same direction, although the rates may vary. There are also regulatory changes, for example, with respect to data protection regulations or acceptance of real-world data for drug and device approvals. And these regulatory changes can either accelerate or decelerate some of these trends. So these are, again, directionally we can see where things are going, but of course surprises are always possible. So we'll have to keep an eye on those things. All right, so let's talk about the value of data. The value of data can be examined from two different perspectives. The first perspective is the value of data to the data custodian or data suppliers, such as a hospital or insurance company that wants to monetize the data. And second, we can examine the value of data from the perspective of the patients themselves. Let's start with the data custodian. Well, the general expectation is that data has financial value. The extent of this value will depend on a number of factors. These factors include data that cover larger populations will have greater value than data that is geographically limited. Coverage can be increased by pooling data from multiple sources or regions. Data sets that cover rare diseases are also going to be more valuable just because that data is harder to get. Third, integrated data sets that cover more of a patient's journey are going to be more valuable. Integration can also involve combining online and offline data, for instance, or say prescription and over-the-counter data. So combining data collected through different modalities in terms of this data integration increases the value of the data. And of course, more recent data sets are also more likely to be more valuable than older data or historic data. Demographics, socioeconomic and status or socioeconomic information and disease patterns change over time, and chances are that data consumers would have a bigger interest in more recent real-world data. Of course, for certain type of data, like clinical trials done a decade or more ago for drugs that are still used heavily today or are still on the market today, this historical data may have a lot of value, but in general, more recent data will have more value than historic data. Another important factor, and perhaps one of the most important ones, is what the data will be used for. This includes the types of analytics that will be performed on the data and the types of decisions that will be made from the data. The same data set may have different valuations depending on its intended uses. And the last thing affecting data value is the issue of data quality. Health data is notoriously messy, and it can take a considerable amount of time and domain knowledge and resources to clean it and make it ready for analysis. The amount of effort needed to get from raw data to analysis-ready data will impact the value of the data. Therefore, as a data custodian, there are three things that you can do to increase the value of your data. The first thing you can do is complement your data with other data sets. So these are things that are under your control. Some characteristics are inherent to the data set and are not under your control, but there are three things that can be done that are under control that I've seen increase the value of data sets, or at least increase what people are willing to pay for it. So first, you can complement your data with other data sets, either by licensing other data or by adding public data to enrich your current data set. And to do that, you need to know how the data set can potentially be used. And then seek out complementary data suppliers and data sources to complement the data sets that you have. Another option is to seek out data exchanges, which allow multiple suppliers to make their data available. And then data consumers can pull the data sets that they want and they need and link them together. And there are a number of commercial data exchanges available today as well. In this case, the custodian is counting on the data exchange to identify complementary data suppliers and enable efficient linking of these data sets, and to also find data consumers who would find value in linking these different data sources. The second thing that I've seen that I think is important is to perform the analytics yourself as a data custodian, rather than commercialize raw data, provide analytics, and commercialize information products. So instead of making raw data available, identify the decisions that need to be made and use your data to enable these decisions by building appropriate models. So you have information products such as reports or decision support tools based on the data are going to be much more valuable than the raw data themselves. As I mentioned before, a lot of data sets are being commoditized. So the analytics and insights from the data become much more valuable. This is not a trivial thing to do, of course, and I think there are at least three important ingredients that are required to ensure success in doing so. Or issues that can impede success in performing this internal analytics and producing information products. The first one is the internal capacity to perform the necessary analytics. There's increasing competition for data scientists who have the necessary skill set to do sophisticated analysis on health data. And more importantly, data scientists who understand health data to be able to work on it. So it's not just the analytic skill. Health data is complicated, requires quite a bit of domain knowledge, and that subset is even harder to find. And then the retention of these individuals in such a competitive environment is also a challenge. Therefore, skill set is the first thing that needs to be worked out before you or before an organization thinks about creating information products from their data. The second thing is the custodian needs to know what are the potential uses of the data and who the decision makers are who can use the resultant models. The people who can make use of your data may not be in your area at all. For example, a hospital may have data that is very useful for the pharmaceutical industry because it helps identify certain patients, where certain patients are, compute disease prevalence and availability of candidates for clinical trials. Hospital staff do not usually interact with the people in the pharmaceutical companies who can directly use these information products. The data custodians can always go through data brokers or other companies who specialize in analytics for certain market segments. But then we're going back to selling data, where you provide your data to the data brokers who perform the analytics and provide the information products to the end users. Another model that is also emerging is where a data custodian provides their data to a company, whether it's an established company or a startup, and then this company builds some models, and then the data custodian seeks an ongoing royalty or cut from all revenues that are generated from the models built using their data. So instead of providing them with data and just charging a fee for that data, they maybe charge a fee for the data, but also arrange a license or royalty, ongoing royalty from the models built using that data. The companies don't like that very much, but that's a commercial model that I've seen being used more and more as a way for custodians to make their data available to external parties who have a good sense of the market. For example, the hospital may license its image database for building models to classify these images using AI technologies. In exchange, they would get a certain percentage of all revenues from the sale of that classifier. Under this model, the data custodian is outsourcing the analytics, but taking a stake in the outcome of that analytics or these analytics. This approach saves the supplier, say the hospital, from having to figure out all the possible uses of the data and bring it to market. And note that I'm using hospital here in my examples, but the argument would apply to other kinds of data custodians. It's not limited to hospitals. If a data custodian is doing its own analytics and is trying to commercialize information products, they need to understand the market very well, and this is a whole business line on its own. Requires having market intelligence, salespeople to be properly capitalized. It's not a small side gig to bring in a bit of extra revenue with minimal effort, which is what I have seen some organizations try to do. In some domains, information products also have a lot of competition. For example, in the area of recruitment for clinical trials, there are quite a few companies offering solutions in that space. It's a big and expensive problem, but that does not necessarily mean that the returns from entering that market are significant, because just a lot of competition, a lot of good technologies out there. So if a data custodian is commercializing information products, then they would be potentially competing against some of the companies that would use their raw data or some of their potential clients. So this is why I've seen a recent trend of data owners trying to cancel their data sharing contracts or not renew these contracts once they realize the value of their data. They're not renewing their raw data commercialization or monetization contracts so that they can do internal analytics themselves and commercialize information products rather than raw data. And I've seen now a few examples of these contract termination and contract non-renewals happening from data suppliers. In this case, they've realized that there's more value from commercializing the information products themselves rather than the raw data, and trying to regain control of their own data. The next thing is keeping in mind that in many instances, the most useful analytics can be quite simple. There are many cases where basic summaries and descriptive statistics provide sufficient benefit and value that by themselves can be very, very powerful information products. There's no need to go straight to very complex analyses and models. Simple models and simple results may be what 80% of the market needs, and is sufficient to launch an analytics capability with the data. So most analyses are simple. Only a small percentage, from what I've seen anyway, are complex. A lot of problems or questions can be answered with simple analytics, so don't assume that very complex AI is needed to actually be able to produce useful information products. Okay, so the third thing on this list is you're able to commercialize information products instead of data. The third thing is improving data quality as a way to improve the value of the data. Improving data quality is not trivial, and it's not cheap. Therefore, it's important to understand the economics of the market to determine the level of appropriate investment in solving the data quality problem. There are also degrees of data quality, and a certain level of data quality may be sufficient for certain data uses. It's therefore important to know where to stop. So in summary then, a data custodian would have some data which is of potential value. There's inherent value because of the nature of the data. But the data custodian can also do some things to further increase that value by linking or integrating data with other complementary data, commercializing information products rather than the raw data, and improving data quality. There's also value of data to patients. A topic that has been coming up is the value of data to patients. So here I will present multiple perspectives on this issue and try to navigate us to a pragmatic outcome. So one of the concerns that has been voiced about the monetization of health data is that some companies are profiting from this data, and that these profits are not necessarily going back to the individual patients. Wrapped up within this argument is the concern that this data is crossing borders and being made available to commercial entities in other countries, whereby the potential benefits of using the data would not necessarily translate back to the local health system. So, for example, the following is a quote from The Guardian on the 8th of February, which is just a few days ago, about the sale of NHS patient data. Quote, Washington has already made clear it wants unrestricted access to Britain's 55 million health records, estimated to have a total value of £10 billion a year, as part of any post-Brexit trade agreement. Leaked details of meetings between US and UK trade officials late last year showed that the acquisition of as much UK medical data as possible is a top priority for the US drugs industry. This was not a positive article. This was a negative article on this whole issue. Another headline, Star article stated, so I'm quoting here, there's a booming business in patient medical records, and up to 5 million Ontarians are part of that boom, whether they know it or not. Physicians or clinics they work for must consent to the sale of anonymized patient data. It's unclear, however, if physicians are making money from the sales or if the profits go to the EMR company. There's no legal obligation to tell patients about or to compensate patients for the sale of their anonymized data. Therefore, one issue that keeps coming up in the media and in various discussions around policy and ethics and legislative reform is whether data custodians should be able to monetize health data without sharing some of these returns with the patients themselves. In practice, this is going to be challenging to do. First, in almost all cases, the data is not personal information. In practice, in most cases, the data has been de-identified or we're talking about synthetic data. If done properly, there will be no reliable way to know the identity of patients in each cohort that's used or disclosed. and re-identification of the data or keeping the information identifiable throughout would increase the privacy risks to the patients themselves, which would not be an ideal outcome. So you don't want to create a situation where privacy risks are increased just to enable the compensation back to patients. It's a non-trivial risk that you'd be adding for that potential return. The other point to consider is what's the actual value of the data to the patients. We don't have really specific numbers on health data, but examining other types of data can be informative. The general conclusion from the information that's available so far is that individual data to individual patients is worth very little. The value of the data comes from it being aggregated into larger data sets rather than individual value to patients. So for example, Facebook's average quarterly revenue per user is only $6.18 based on the company's 10K report for 2017. For 2016, Google's quarterly revenue per user was $6.70. After subtracting costs, the net revenue per user would be even less. So based on the information that's available, and I have some numbers from other organizations, and it's comparable when you compute the total revenue of the organization from data sales to, or data revenue to the number of individuals in those data sets. So that these numbers are not unusual, but they're public, so I can quote them. Therefore, based on the data that's currently available, the returns to users can be very small, unlikely not worth the risks of maintaining a mechanism to identify the patients in the data. Furthermore, if we allow patients to opt out of their data monetization, which has been another proposal made within the community, this would have the effect of ensuring that the patients with higher socioeconomic status being more likely to opt out, while those with lower socioeconomic status with a relative data value may be more meaningful, remaining in the data and not opting out. In addition to the obvious discriminatory effect, we would have systematically biased the data that would further reduce the value of that data, because then you'd have systematic bias on the socioeconomic status variable. Therefore, irrespective of the technology that can potentially be used to compensate patients, which includes blockchain, which has been one of the other proposals, the basic model seems to be difficult to make work well in practice for the reasons I mentioned. So a better approach would likely be a data for good mechanism that some organizations have started to adopt as a way to give back to the broader community. And so we'll examine this concept in the next section when we talk about social license for monetizing health data. But just to summarize, providing compensation directly to patients. I'll return to that topic later on as well, but it's not straightforward to do. Okay, so let's talk about social license and transparency. As you have very likely seen in the media, there's been some general unease about the data economy, but also there's a lot of confusion about it. As a starting point, again, I'm making the point that we are talking about the uses and disclosures of non-personal information. So it means the data has been de-identified, or we're talking about synthetic data that has been generated to have the same statistical properties as the original data. One other observation that I think is worth making is that the bar is quite low for a crisis. This may be negative story in someone's blog, social media, the media in general, or for investigation being triggered by a regulator. But my general observation is the bar is low for negative outcome. Therefore, good governance and implementing best practices for data monetization can position you and your organization better should there be a challenge like this. The other thing I'll mention is the de-identified data or non-personal data assumption is important because monetization of personal information would have additional constraints and obligations under the California Consumer Privacy Act, which regulates the sale of data, with the sale being broadly defined. So there are 4 things that an organization can do to to start getting social license to monetizing this non-personal data. You have to realize that not all data uses and disclosures are in the public interest. Sometimes organizations will use data to generate revenue, for example, to market their services and products and to raise money for their activities. There's nothing wrong with that. It feels somewhat silly that I actually have to say this, but there's a narrative in the privacy community that views for-profit uses of data negatively. So 4 important things for social license and good practices that organizations can follow to avoid negative narrative around this. So the first is to get and retain social licenses transparency. This means at least providing notice to patients that their data will be converted to a non-identifiable form and then used and disclosed for secondary purposes and monetized in some manner. In some cases, such notices may be provided at the point of data collection, for example, when a patient signs up for a service or gets a drug or a device, or in some instances providing notice at the point in time. That point in time may not be practical, and therefore the notice is provided on the organization's website. The notice should also mention the benefits of the data monetization efforts. Even if the benefits occur a few steps further along from where you are, it's important to emphasize the benefits. Again, I'll go back to analytics to help recruit patients for clinical trials. These support efforts to develop and evaluate new drugs and treatments and to bring them to market. It's an important part of the overall process, and therefore emphasizing the benefits, although it's not always done, I think is an important part of the narrative and should be injected in any notice. You should also keep in mind that a well-established behavioral economics result is that when you prime individuals about privacy and data uses, they become sensitized to it, and their level of concern goes up. So it turns out that the less patients know, the less they will object. By informing patients of data monetization efforts, some will have questions and concerns, and you should have the processes in place to answer them. For example, having a number, an email address, or a call center where patients can ask questions about how their data is being used. Another good practice that has been adopted by some organizations is to have a data for good initiative. This means making the same data that's being monetized available for public interest purposes at no or a nominal cost. For example, making data available for academic research. There are some skeptics about this. They see it as a public relations exercise, which is fair. And I really like this characterization by Jules Polanetsky from the Future Privacy Forum, where he wrote recently that many critics think that your data is the fruit of the poisonous tree, unfairly collected, or don't think your corporate view of good is necessarily the view of the communities whose data is used or who are impacted by the project. So there's definitely skepticism about data for good initiatives. And I have seen data for good initiatives that are not really achieving their intended objectives. For example, by making data available to academics, but requiring that all IP generated from that data and the analysis of that data to be assigned back to the data provider. And this is a condition that most academic institutions will not agree to, or at least not easily. So in this case, it's a data for good program, but it's not really that good. So if you're going to go through the effort of setting up a data for good program, they have to be implemented in a manner that has a high probability of achieving its objectives and fulfilling some broader public interest objective, as well as, of course, the commercial interest. The third point is also it's a governance-related point, is to have some oversight on data uses. Some people would call this having an ethics review process to ensure that the analysts working with the data, whether they're internal or external to the organization, are not using the data in a discriminatory, creepy, surprising, or harmful way to patients. This oversight also applies to the decisions that are made using models built from the data. And then the other thing I would suggest is proactively talking to regulators about how you're using and disclosing non-personal data and about the data monetization efforts. This will allow you to get informed feedback about any concerns from your regulator and ensure that should anything go wrong, the regulator is already aware of the practices, there are no surprises, that you're you have practices to manage risks. Of course, if something goes wrong, the facts of the case will matter, but having a pre-existing communication channel can be helpful. So you may ask why all this data for good governance is necessary. And there have been a few examples recently, over the last 12 months, whereby civic society and consumer advocates found out about data monetization efforts. There's some examples in Ontario, and intervened to stop, change, or significantly delay these efforts. These were efforts in the public sector, and this is why they were public and we know about them, but I've seen this happen as well in commercial settings. So for commercial or private sector projects, it has been known for the media, investigative journalists, and whistleblowers to put data monetization efforts out for public scrutiny, and when proper governance is not in place, things don't end well. So these practices are important to have in place. The other consideration is these are a lot of practices, and maybe too much for small companies or startups. The cost of implementing all of these types of programs is not trivial, and for small companies, inching towards scalability while burning through investor money, establishing social license for data monetization may get lost in the large stack of urgent priorities. So as a pragmatic step, I think the more of these things that can be implemented early on in the business, the better, because sometimes, even frequently, it's much more expensive to put them in place afterwards or after the business has grown. But I think focusing on some aspect of social license, even for startups and small companies, is a prudent thing to do, just given the directionally where the narrative around data monetization is headed. All right, the next, I think, big topic is data quality. So health data is often very messy, and messiness comes from multiple sources. There are data collection and data entry errors. Some analysis has estimated that health data variables have a weighted average of 4.6% probability of being an error. That's actually quite high, because when you combine many variables, 4.6 for each one of them, adds up to a large percentage of records in a data set having some kind of error in them. And also codes that are provided in the context of, or that are entered in the context of providing care, are optimized for certain objectives, for example, for billing purposes. And then you have free-form text, which can describe problems, history, background, and procedures in many different ways, requiring some additional cleansing using natural language processing tools. For some types of data, standards exist, and there are data validation tools to confirm that the standards are met and the data are internally consistent. This is, for example, the case with clinical trial data. So if there are data validation tools, they can be very powerful in checking data quality, but also in signaling to the market that the data is of adequate quality. Data that's collected directly from medical devices will have far fewer quality problems, but even then calibration issues may come into play. For example, in one project I was involved in, where results from scans from MRI machines were being analyzed, the scans were not easily comparable before and after maintenance, because at maintenance points the calibrations were changed. And therefore, maintenance points had to be included in subsequent analysis. Okay, so as mentioned before, data quality can have a non-trivial impact on the value of data. Sophisticated data consumers will have methods and checklists to evaluate data quality before they commit to using or acquiring a particular data set. And sometimes they have to go through many data sources to find good enough data sets. So even if data exists, it doesn't mean that it has adequate quality for the purpose. So as a data consumer, you should not take for granted that just because a data set exists, that its quality levels will be adequate for the purpose of your analysis, and it would be prudent to have in place a quality assessment process and quality assessment checklist. For data providers, improving data quality improves value, but it's often also hard, time-consuming, and expensive. Sometimes it's the nature of the data to have a certain level of quality, and affecting that quality requires changes in behavior or technology at the point of care, which is hard to do. Sometimes data can be cleaned after the fact by, for example, using multiple sources of information to improve the coding. If data suppliers don't improve data quality, then data consumers will have to do it. So it's just a question of where the economic burden will be placed. If you place it on the data consumers, then the data will be worth less because the consumers have to incur additional costs to make the data useful. Another consideration when talking about data quality is harmonization. So in cases where data from multiple internal or external sources need to be pooled, different data sets have to be harmonized. And a basic thing is to map all the fields to a common catalog. For example, all the fields that measure age should be mapped to a single age definition so queries can be run across all the pooled data sets on age. Then, of course, the exact definitions have to be harmonized as well. Even something as seemingly simple as age can be measured in different ways. So in any case, the definitions of fields need to be harmonized to enable pooling. Harmonization can be automated to some extent, but it's also time-consuming and costly, and this should also be considered as part of the economics of data monetization. And then if real-world data is going to be used in regulatory submissions, then evidence on data quality assessments and levels will be necessary before data is deemed acceptable for the submission, which brings us to the need for adequate and detailed data quality documentation as well. So a number of factors here to consider around improving data quality and by the suppliers, and to assess data quality by the consumers to determine the value of the data and also the economics of using that data. Next, I will talk a little bit about data markets. So data markets are intended to allow data suppliers and data consumers to find each other. They're often online platforms with powerful search capabilities for finding relevant data sets. Some data market platforms are targeted at very specific types of data, such as only clinical trial data, and others are more general consumer data. The economic model for data market platforms also vary, with some requiring the data suppliers to pay to make their data available, and the data is provided for free for the data consumers. This is the case for many clinical trial data platforms. In other cases, data suppliers can register their data, and a financial transaction occurs when the data is purchased or used by a data consumer. In this case, the data consumer covers the cost. The services provided by the data market platforms also vary. Some provide a computing sandbox. So in such a case, the data analyst selects the data they want, the data is put into the sandbox, and then the analyst can work on the data inside that sandbox. The analyst is not able to download the data in this case, and they can't run it in their own environment. They have to run all the analytics within that sandbox environment. Another type of capability is to allow different data sets to be linked within the platform. So under this model, unique keys are assigned to each record in each data set, which enable the individual records to be linked across all of the data sets that are selected, or at least across many of them. And then, of course, there are data market platforms that just let you download the data. Google's recent dataset search capability is an example of a search for data platform by essentially indexing metadata. And then after you find the data sets that you want, you have to negotiate with each supplier to get access to their data. There are also data market platforms that aggregate public data sets, making them more usable and accessible. So it's not necessarily also private data from various data sources. You also have cleaned, ready-to-use public data set markets. So all the issues we've talked about here with respect to data quality, privacy-enhancing technologies, social license, and are relevant for the consumers of data in these data markets and should be considered as part of the due diligence into the data markets by the data consumers. Data valuation is also an interesting topic in these data markets. Some static data sets are available for a flat fee, and you can just download them. In other cases, it's a subscription to access the sandbox with the data on it. Sometimes the subscription fee is fixed for a certain amount of time or contingent on the compute capacity that's made available and that's consumed. Data pricing can also be dynamic. based on the level of demand for a particular data set, demand being an indicator of its value. My observation is many data analysts are not a big fan of working within sandboxes. They prefer to download the data and work on it within their own environments. That entails, of course, high data privacy and security risks on the data supplier. But in any case, most data analysts will put up with sandboxes if it's the only way to get access to valuable data. Plus, the capabilities in these sandboxes are getting richer and better all the time. An important consideration is data archival and data archival costs when data is processed within a sandbox. In many cases, copies need to be retained for an extended period of time, and copies of the processed data as well need to be retained for an extended period of time. So the costs are not only limited to the subscription for when the analysis is being taken, it also has to account for long-term archival of the data in case there are audits of the analysis that was done. Let's talk about pets. So privacy enhancing technologies, which are needed if you're going to be sharing non-personal information. So a basic premise here has been that data is not personal. If it's going to be personal, then that raises a whole new set of issues and obligations that need to be addressed, which are really beyond the scope of our conversation today. So we're talking about non-personal information. The number of methods that can be used to render personal information to be non-personal. These are, I'm going to mention three today: data identification or anonymization, synthetic data, and federated analysis. Federated analysis can use methods for secure multi-party computation, or there are other approaches. I'll focus on data identification and data synthesis, as these are the most scalable approaches today and the most commonly used. The reason why it's better to convert data to be non-personal or transform it is that once data is no longer personal information, consent or authorization from the patient is not needed for these secondary purposes. Also, because it's no longer personal information, the obligations in the various privacy regulations do not apply anymore. Of course, there's pushback on this. The public and regulators are not comfortable with data being used and disclosed for any secondary purpose without limits once it's rendered to be non-personal. That's why the various practices that I mentioned before in the context of social license and transparency are very important, as they can mitigate, to some extent, these concerns. But it's also an evolving dynamic, and therefore you need to keep an eye on this. So if you want to have a data set and you remove the names and addresses from the data, it's still personal information. I see that quite often. Removing names and addresses is not good enough to make the data non-personal. If you do that and encrypt all the social security numbers and encrypt all the medical record numbers, and both of which are unique identifiers, the data is still considered personal information. I still see organizations doing that today, and that they treat data as if it's not personal information after they remove names and addresses and encrypt social security numbers or medical record numbers. These simple approaches will just not withstand scrutiny. So the next step up in terms of sophistication is the Safe Harbor data identification standard and the HIPAA privacy rule. So this is the one on the right in this picture. These are the two standards under the HIPAA privacy rule. The Safe Harbor standard requires the removal of 16 fields and generalizing all dates to a granularity of a year and cropping almost all zip codes to the first 3 digits. So essentially 18 things that you need to do. These 16 fields that have to be removed are unique identifiers, social security number, name, address, fax, telephone numbers, biometrics, and so on. Even though many organizations that are monetizing data are not necessarily covered by HIPAA, the HIPAA Safe Harbor standard is followed and is used quite extensively because it's easy to understand and quite formulaic. From a privacy perspective, or privacy protection perspective, the Safe Harbor standard is actually not a very good standard. Given the complexity of health data, a simple method like the HIPAA Safe Harbor method does not provide adequate protection, and data sets that do meet the Safe Harbor standard are often quite easy to re-identify, relatively speaking. There are more sophisticated methods, such as statistical methods, and this is essentially the expert determination. The second standard under the HIPAA privacy rule here on your screen. And risk-based methods involve two things: transforming the data and putting in place controls to manage the risk, security, privacy, and contractual controls. Data synthesis is a completely different approach that takes real data, creates a synthetic version or twin of the real data, and then a model of the real data is built, and that model is used to generate new data. And this new data, synthetic data, has the same statistical properties as the original data. Because the data is synthetic, there wouldn't be a one-to-one mapping between the synthetic records and real people. And there's a book that we're publishing on this topic that should be coming out in a couple of months as well, if you're interested in learning more about synthetic data. So these approaches work in practice, each with its own strengths and weaknesses, but they do provide the data supplier with defensible methods for rendering the data to be non-personal. Okay. Of course, there are controversies that I've seen come up when data is processed for secondary purposes. One is when data is re-identified or linked back to real people legitimately. But for example, if you use a data set to identify records of patients who are eligible to participate in a clinical trial, then the record numbers, which are completely meaningless to the analyst, are passed back to the physician, who is then able to reverse or decrypt these record numbers and figure out who the patient is. The physician then contacts the patient, which they are treating, and propose that they participate in a particular trial. This workflow does not reveal any personal information to the data analyst working with the data on the data consumer side, but the fact that records can be linked back to the patient as part of the workflow has raised concerns and criticisms. And then the second controversy pertains to anonymous profiling. The basic use case is when an advertiser has a series of events about an anonymous individual. For example, they've ordered a cold medicine and they live in the east end of town, where the general socioeconomic status is high. So the advertiser can then use that information to target ads, even though they don't know the actual identity of the person. So even though the ad delivery is practically anonymous, because the advertiser does not have a reasonable or lawful way of associating a correct identity to that profile, let's say contemporary chatter among some in the privacy and regulatory community is that this is still intrusive. So this brings me back to the whole concept of governance and social license and transparency and so on. Good governance matters. Okay. Let's talk a little bit about data ownership. So data ownership is something that has come up. Some arguments have been made in public discourse that patients do or should own their data. One consequence of that is that patients should be compensated for any revenue generated from their data. As we saw earlier, this is not an easily workable arrangement. With respect to ownership rights, implementing that has its own complexities. For example, should offspring or siblings also claim ownership to someone's genetic information? So who actually owns the data? Or how would ownership rights be extended to someone who cleans the data, creates a clean version of a data set, or derives some new version of the data set, a derived data? The answers are not very obvious. In any case, under current law, patients do not have ownership rights to their personal health information. For example, Canadian courts have recognized that the provider has a property right in the medical record, and the patient has an interest in the data that gives them a degree of control over that data, but not an ownership right. The Supreme Court of Canada explicitly considered and rejected arguments that the patient interest was a property interest. Similarly, in the U.S., case law currently does not support individual ownership rights in personal data. Of course, laws can change over time, interpretations of laws can change over time, but that's where we currently are. So while there are discussions around data ownership legally, the concept of patient ownership of their own data is not supported by law. Okay. Let me move quickly to the next topic. I'll skip dynamic consent and move to the last two topics. So nightmare scenarios. So I decided not to put nightmare scenarios at the end of the presentation because I didn't want to end on that. Therefore, I put it here as number 9. This is a picture of Slender Man, who just because it shows up in my nightmares, and therefore it seemed like a good picture for the nightmare scenarios. In any case, I think a nightmare scenario would be if the regulators decided to regulate the uses of non-personal information because of concerns about how data is being monetized. This would go beyond current regulatory regimes whereby non-personal information falls outside privacy statutes. But I've been hearing comments from regulatory and supervisory bodies that they are unhappy that there is no oversight on non-personal information. This would be a huge problem from a number of perspectives. First, it would create disincentives to render data non-personal, which will mean that there is more personal data being monetized, which increases the overall risks to patients. Second, data uses are so varied and changing over time, any specification of acceptable and unacceptable data uses would be out of date very quickly. And if there's a requirement to get approvals for secondary uses, that would significantly slow down innovation, especially that regulators do not really have the capacity to oversee all secondary uses and disclosures within their jurisdictions. They'd just be overwhelmed. So an alternative then that's sometimes been proposed is to require consent from patients for all data uses and disclosures. And I think this would create the same disincentives as the first approach, plus puts limits, plus the limits of consent are well known, and it's not obvious that increasing the level of consent from patients is going to help them exercise control over their data. So a reasonable approach, I think, is to implement or require the implementation of good governance practices that we spoke about earlier on as a way to manage the risk from data monetization when the data is not personal. The last point I will mention is organizational design around data monetization. So to be able to effectively monetize data internally rather than trying to commercialize it externally, a number of specific things have to be in place. The first is the right organizational design. The second thing is leadership. So a McKinsey survey comparing leaders and laggards in data monetization found that leaders are more likely to have a center of excellence leading the data monetization and analytics effort. Even though the individual business units are involved, a center of excellence maintains core competency, ensures that governance and data protection technologies are in place, develop reusable assets across the organization, provide training on analytics and governance to the business units, interface with the outside world, including interfacing with regulators, and processes and develops enterprise-wide tools to support the business units in their data monetization efforts. We've been advocating this type of organizational design or setup for the implementation of data synthesis as well. It's a good setup for these types of secondary uses and disclosures of data. So going back to the McKinsey survey, senior management involvement in data and analytics activities was found to be one of the key contributors to data monetization efforts achieving their objectives. Again, leading organizations said that their executive teams spend more than 20% of their time discussing and participating in their data and analytics activities. While this survey is not specific to healthcare organizations, I think the key learnings are more broadly applicable. And in a separate PwC survey, data silos was highlighted as a key obstacle for organizations to be able to use and monetize their data. So inability to break the silos among business units and share data internally. Where data exists within business units, data is not visible or available to other parts of the enterprise, it will be difficult for an organization to really leverage its data assets if they don't know where the data assets are and who has them. So typically one of the first functions of a center of excellence is to get an inventory of all the data assets within the organization, including copies and duplicates. And then the inventory would include metadata so that there's at least a basic understanding of what's in these data sets. So if you've been listening carefully to everything I've said, then you already know how to address the other items that have been found to be obstacles to effective and responsible data monetization. With that, I will close. Good luck in your data monetization journey. If you have questions, you can always send them to me by email. I know we're out of time. If you have type in one question, I'll answer it, and then I think we'll have to close. So examples. So one question was examples of data market platforms. I work with some of those companies, so I don't want to prejudice the market. But I think if you Google data platforms, then you'll get some hits, and also the large data brokers are a good place to go if you're looking for catalogs of data sets that are available. Okay, I think we'll close here because we're at the top of the hour. Thank you so much for your time. As I mentioned, I'll send you the materials,